So we are now back with Dr. Berteau after his presentation here today. Thank you all for your questions that you submitted through the chat feature here this morning. We're going to try to plow through and answer as many of them as we can. Great job this morning, Doctor. Thank you so much for sharing your insights and your knowledge with us. I got a nice bunch of questions that folks have contributed here this morning. Let me throw the first one at you. This one is regarding metformin benefits of IR versus ER. What are your thoughts on that one?
Yeah, it's a good question. I will typically actually jump to the ER first, simply because it's usually tolerated easier. And if you order it 500 milligrams ER, it's very inexpensive. I don't know why the 1,000 milligram ER is expensive, but obviously you can use two 500 ERs twice a day if you need them to take 1,000 twice daily. So I typically start with the 500 ER. If the patient is already on the immediate release and they're tolerating it just fine, I don't tend to make the switch. But if I'm the one starting the metformin, which is very rare as the specialist, usually they're on it already, I'll start with the ER first.
Okay, great, excellent. And this one references in your presentation, you had mentioned weight loss as a means of reducing blood sugars. And this person asking this question wonders if you encourage patients, especially early onset folks, to implement any intermittent fasting or even the use of berberine in reducing A1C and blood sugar.
So I'm definitely a proponent of intermittent fasting. There's been documented evidence that shows that it's safe and effective for type 2 diabetics. And they can do that in multiple different ways, either closing their windows, hours on how often or their eating hours, closing that so that they're eating fewer hours in a day. Or some people will do, like for example, do a complete 24-hour fast once or twice in a week. So whatever works best for the patient. Again, those I'm supportive of those, and those do work. The berberine, I don't typically recommend berberine, but I have heard berberine is effective with helping with diabetics. So if a patient asks me, I say, yeah, I've heard some good things about it, and I certainly wouldn't discourage them from trying it.
Great, but sounds like a nice green light for intermittent fasting there for folks. So that's super encouraging. Yeah. That's great. Mm-hmm. Excellent. And next question come through here for SGLT2 inhibitor UTI or yeast infections. Is it okay to continue the SGLT2 inhibitor, stop for a period of time, or discontinue indefinitely?
Yeah, it's a great question. So here's my rule of thumb. I tell the patient, if you get a urinary tract infection, let me know. I'll treat the urinary tract infection. And usually when I'm treating the urinary tract infection, I leave them on the SGLT2 inhibitor. And I recommend that we'll just treat it one time. If it happens a second time, obviously let me know. I'll treat it a second time, but the second time is when I stop it. So I feel like if it's happening multiple times, it's not worth the benefit. But if it just happens once, which is actually very common, I think it's worth treating once and then keeping me on therapy.
Okay, great. This is an interesting one coming up here. Which of these medications are contraindicated when a patient has an alcohol use disorder and the patient is not motivated to quit or reduce? We've done a couple of different med-zeds with a strong AUD focus over the last year. So I know a lot of folks are trying to redouble their efforts as far as applying treatment towards AUD. So I'd love to get your thoughts on that.
Actually, do we have any of the pharmacists available? Maybe they can help me with this. I know that I've got a small handful of alcohol using patients. And while it's very tricky and difficult to manage their sugars while they're drinking alcohol, I haven't really ran into any problems with utilizing these meds. But if a pharmacist can help me with that, that'd be great.
Well, I got another Q&A. We had to do the timing and broke our Q&A segments up into 2 of them today, just to make sure that we had everything sorted out correctly.
Okay.
We're gonna have Corey and Melissa back for their own Q&A after Corey's segment at the end of your Q&A. So we're gonna cover all kinds of
So maybe we can
a little bit of Scotch tape here and there to
that
accommodate everyone today. So that's good. Let me go on to this other question here that just came in, because I think this is great. On the heels of intermittent fasting, Nancy with Multnomah County asks if you have like a written resource that you recommend to share with patients about intermittent fasting. Anything that you recommend that we could show them?
Yeah, that's a really good idea. Unfortunately, I don't have any. I used to have a dietitian that I could send my patients to, and she was quite knowledgeable about intermittent fasting, give them lots of information. But unfortunately, we're still looking for a new dietitian right now. So there's lots of information available online for patients, and usually once I kind of steer them towards intermittent fasting, they're able to find a lot of information online. So that hasn't been a difficult thing for them.
Okay, awesome. And let me go back over into this longer questions. They're still coming in. So a lot of people have great thoughts here today. Any thoughts on using mealtime insulin in addition to GLP-1 agonist?
Yes. So oftentimes, basal insulin with a GLP-1 agonist takes care of all of their needs, their long-acting needs and their mealtime needs throughout the day. But there are a few diabetics that have had the disease long enough to where they're really not producing much in the way of insulin. So putting them on mealtime insulin and using the GLP-1 agonist can actually have some really favorable results. I've had multiple cases where that combination works really well. So I'm not afraid to use those 2 together at all. And I've had some great results with it.
Awesome. Very good, very good. And here's one asking, how can health at every size principles be included in diabetes management? Health at every size principles.
I guess I'm not sure what health at every size principles is, but my guess is, and this is kind of my philosophy, I meet the patient wherever they're at. And if they're very obese and they're unable to do a lot of physical activity, I meet them where they're at, gain some positive momentums to begin with, and then kind of pull them along the pathway of getting better. Oftentimes, if you can make small gains, that really charges the patient with some positivity, some benefits, and so then they're more active, more likely to take further steps in their health. And oftentimes I am able to get some larger patients to become more physically active by just small steps. And that's one thing that I really encourage patients is if they're going to do exercise, start small. Do anything to begin with and do it every day, and then just slowly build on that. You want to set them up for success, and so long as they're making improvements, it doesn't really matter how far down that they start. I've had some patients that will get an exercise bike and literally start with just doing like 2 minutes daily on the exercise bike, and that's great. Then we bump it up to 3 minutes, and then 4 and 5, and pretty soon I've got them exercising, and it pays off really big dividends in their blood sugars.
That like just behaviorally doing something consistently, just showing up and doing those small things, and they can gradually become more cemented habits, right? I mean, isn't that
Yes.
what we're always hoping for?
Yes,
excellent.
Exactly.
And then let me make sure, I think there's a couple more that we have on here that are really interesting. This one's really interesting. I'm sure this is a common challenge for folks. As far as dietary recommendations, like say fasting or traditional diets, how do you navigate those conversations with patients if they have like a history of disordered eating?
Obviously, you stumped me on that question. I'm trying to think back of patients. Yeah, one in particular, she is hyper focused on not gaining back weight, and it's been very difficult and delicate, the conversations that we have with her. I'm on the same side of the fence with her. Obviously, I don't want her to gain back the weight, but I also know her history. And so we have to be really delicate when we have frank conversations with her. I would just say, just take the time to walk through those conversations delicately with the patient, and usually they're well aware of their history, and so they know the common goals that they need to accomplish. And like I said, with that one particular case, she's hyper sensitive about gaining weight. So usually that side of the conversation is easier to have with her. And that's really the only case that I can come up with. The majority of my patients, it's the opposite. Their eating disorder is they're eating too much, and they all kind of know that that's their issue, their main issue. And I found that those conversations are a lot easier to have with patients than not. They know what the issue is, and that it's an issue that they have to work on. Usually you can be pretty frank with them. What's been interesting is bringing up the conversation about bariatric surgery. That one is really difficult. It's hard to read the patient to know if that's a subject that they want to bring up or not. Some patients have been very positive about that thought and want to move forward with that. Other patients get extremely offended and don't want anything to do with bariatric surgery. So that one's kind of hard to kind of feel the waters, if you will, to find out, well, how's this patient going to react to that question? But sometimes I'll broach that subject very cautiously and just see where they want to go with that.
Excellent. So every situation is probably a little bit different, personalities,
Exactly.
And everyone's background. It's part of the challenges that everybody's facing all the time. I had a heart failure question come in here about patients with type 2 and also with heart failure with preserved ejection fraction, and wondering if you have a preference in using either Farxiga versus Teglatro.
Farxiga. There's definitely been documented evidence that shows that Farxiga prevents a patient from going into uncompensated heart failure, whereas the Teglatro really doesn't have those benefits. So yeah, I would much prefer Farxiga over the Teglatro in that scenario. Obviously, just as a reminder, I should probably steer clear from the pioglitazone in those types of patients.
Okay. And I know a lot of folks right now are navigating situations where kids are beginning school, going back into like new grades or high school or things like that. And this question is here asking to speak to the evidence around sitagliptin and preventing serious COVID. Does it really work? And then it looks like this is sort of a follow-up question here. How do you work with adolescents with type 1 who may be skipping their insulin to lose weight or struggling with medication adherence?
Yeah, that's really difficult. So let me go to the sitagliptin. That's the first time I've ever heard of sitagliptin being used to help prevent COVID. So I don't have any evidence that I've been exposed to. Like I said, that's the first I've heard of that. So sorry, I won't be able to comment on that, but I'm going to look into that now that I've heard it. And then the other one, while I don't deal with adolescents, I guess I will see them as young as like 17, 18. That's a common scenario, especially with female type 1s that figure out that if they skip their mealtime dose, that they can get away with eating the food and not necessarily gaining all the weight. And that's a really dangerous combination once a young female's type 1 diabetic has figured that out. And you can call them on it and say, look, yeah, you're making this trade-off, but you're sacrificing your eyes, your kidneys, your feet, and they just don't really get the gravity of their future complications. To them, it's worth that trade-off. If I get problems in the future, oh well, I can fit in my skinny jeans now. And so that can be very hard to overcome that inertia. And in some cases, I wasn't able to overcome it until later in life when they did get the complications. And then they're like, okay, I better take this serious now. I'm going to start taking my insulin before I eat. Oftentimes when I get somebody who you can tell they're not taking their mealtime doses, and then you follow them throughout the years, and then all of a sudden they start taking their mealtime doses, and you can tell, wow, your blood sugars are looking great. Are you taking your insulin before you eat? And they're like, yeah, I've finally started doing that. And so I'll ask them, well, what was it that changed your mind about that? What was it that got through to you, so I can know for future patients? And every single time it's like the patient just comes to an epiphany. They're like, I just decided it was time. It was right for me to start doing it. And unfortunately, a lot of times we have to wait until complications start. And that's when they'll finally say, okay, it's time to start taking better care of myself.
Reinforcing those motivational interviewing principles, right? That each individual is the best expert on their own circumstances, right? When they're ready to have that epiphany, they're ready to have that moment of like, what motivates me? Then that's when they're ready to actually execute change. So that makes good sense. I think we got one more question through here, and I think this is kind of building on what you were just referencing a little bit earlier, Doctor. Here, at what point do you suggest bariatric surgery or address it if the patient brings it up?
I'm pretty quick to address it if the patient is motivated to do it. It's pretty much indicated for most every diabetic, because that diabetes counts as a complication that bariatric surgery can fix. And so if they've got weight to lose and that's how they want to go about doing it, I'm quick to make that referral. But again, when do I start thinking about it from my perspective to bring it up in the conversation? Obviously, these are pretty heavy patients. I'd say at least a BMI over 40. You can do it at BMI over 35. But I guess I'm thinking of it more when they're pretty substantially obese. And again, it's a delicate conversation that you have to have. And so sometimes I just kind of float the idea a little bit in conversation and just see how they react to it.
Excellent. Fantastic. And I'm going to see if we can squeeze in this last question that just came through here. Does adding more insulin in type 2 just increase insulin resistance? And when do you decide to start insulin? Do you use all other orals and injectables first? I'm getting deja vu with this question.
Yeah. So yes, if you're using insulin, that can make them gain weight, which is making the insulin resistance scenario even worse. And so oftentimes, if weight is an issue, I do try and go the other routes. The SGLT2 inhibitors or the GLP-1 agonists help with weight loss. And so I'd much prefer to try those in my obese patients first before having to go to insulin, which isn't helping the situation. But oftentimes getting those paid for can be difficult. And like hopefully I mentioned in my presentation, with Care Oregon, I do think that we can kind of circumnavigate the protocol on that flow sheet in patients that are obese. And if our big issue is insulin resistance and obesity, oftentimes we can make exceptions in that pathway and get the GLP-1 agonists or the SGLT2 inhibitors paid for earlier in that process. What was the other part of that question again?
When do you decide to start insulin, and do you use all other orals and injectables first?
Oh yeah, I guess I did answer that pretty
well.
Then
adding more insulin, someone sort of, I know we've had this come up before, does adding more insulin in type 2 just increase insulin resistance?
Yeah. So it's through the weight gain. Insulin causes weight gain. Weight gain increases the resistance.
Perfect.
I guess I answered that question better than I thought.
Well, I think we've gotten a big chunk of questions taking care of this morning, Doctor. I know how incredibly busy you are, particularly on a Monday, undoubtedly. So we just want to extend a huge thank you to you for being so gracious and generous with your time this morning, for your presentation, and then to be able to take the extra time to answer these questions here for folks today. Given the state of trying to get treatment going in the times we live in, it's just been hugely appreciated. It's going to make a tremendous difference for folks. So thank you so much for being such a great collaborator and coming together to help us do this. We're just super grateful for your participation and for everything you do for the patients in Oregon. So thank you, Doctor. We really appreciate it.
Great. Thank you for having me.
It's been a pleasure. And folks on the webinar, we are getting ready to move to our next segment here. We just have a couple of connections to make and get one system up and running. If you would just give us, I promise, only 2 minutes for another short break. Very, very short this time, just 2 minutes. We'll be right back with one of the craziest members of the Kerrigan family you ever met. So how's that for a little tickler to get you going? I'll explain why momentarily. Thank you.